Hi, today we are going to talk about pre-hospital fluid therapy. This presentation will first outline the major pathological factors of inadequate perfusion and hypovolemic shock, which would lead into a comprehensive analysis of the advantage of IV fluid therapy preventing organ ischemia and death from hypovolemia. Likewise, many forms of treatments, contraindications, and risk factors are apparent in IV therapy in the pre-hospital setting. These risks will be identified throughout the presentation whilst demonstrating that such scenarios do not contradict IV fluid therapy in the entire pre-hospital settings. So what is fluid therapy? Fluid therapy is when you give a patient fluid through a cannula via the intravenous route rapidly. What types of fluids are there? There are three main groups: colloid, crystalloid, and blood products, where each of them are made up of different chemicals and have different uses. The type of fluid that we use as paramedics in the pre-hospital environment is 0.9% sodium chloride isotonic crystalloids, otherwise known as normal saline. It is the most common and cost-friendly solution that is most widely used and widely available in a pre-hospital setting. It's made out of sodium and chloride. Both components can move freely in and out the circulation. Therefore, not only it can increase the volume of the blood vessels, it can increase the volume of the extracellular fluids. So when do we use fluid therapy in the pre-hospital situation? It is indicated when there is an inadequate perfusion or shock or hypovolemic case.
According to Hovmir and Malala, 2001, hypovolemic shock is when there is a decrease in the mean systemic filling pressure, causing decreasing circulatory volume and therefore inadequate perfusion to tissues and cells. Hypovolemic shock can be the result of many causes, for example, burns, controlled or uncontrolled hemorrhage, trauma, sepsis, and dehydration, just to name a few. All these lead to an inadequate systemic volume and a reduced circulatory volume returning to the heart. Severe volume loss results in the heart not being able to pump enough blood around the body. This is defined as hypovolemic shock. Curtis and Ramsden, 2011, explains that baroreceptors detect a decrease in blood pressure, thus initiates a cascade of flight or fight responses. In the early stages of hypovolemia, Holliday 1999 explains that the body responds by drawing fluid from extracellular space directly via blood vessels or movement through lymph nodes in an attempt to increase the circulating blood volume. The body also compensates by promoting peripheral vasoconstriction and diverting blood to mainly perfuse vital organs, including the heart, brain, skeletal muscles, and lungs, as justified by James 2014 and Curtis and Ramsden 2011. However, hyperperfusion of peripheral and other organ cells is the result. Hofmeyr and Malala, 2001. The loss of circulatory blood volume or blood supply at cellular level results in an insufficient delivery of nutrients and oxygen, electrolyte imbalances, as well as decreased clearance of metabolites, as mentioned by Revel and Porter, 2000, and Hofmeyr and Malala, 2001. Hofmeyr and Malala, 2001, also states that lysosome rupture can also occur, resulting in release of enzymes that contribute to intracellular digestion and increase of intracellular calcium, which leads to irreversible cell damage. Furthermore, without the delivery of oxygen to cells, the cell membrane pumps fail irreversibly, causing permanent damage. Nolan, 2001. And because the energy molecule ATP can be only produced by the anaerobic glycolysis, as there is no oxygen, this leads to a buildup of lactic acid, causing lactic acidosis. Curtis and Ramsden, 2011. Hypovolemia, if left untreated, will continue to amplify damage to cells, eventually causing irreversible cell damage, decreased contraction of muscles, organ failure, for example, acute kidney injury, impaired neurological function due to cerebral hyperperfusion, cardiovascular decompensation, myocardial ischemia, heart failure, and ultimately death, as mentioned by Hofmeyr and Malala, 2001, Cassia, 2014, and Nolan, 2001. So how can we prevent hypovolemia and its detrimental effects? Appropriate IV administration is a great intervention to replenish fluid volume loss and to minimize the number of cells that damage irreversibly. According to Nolan, 2001, restoring intravascular volume is more important than giving the patient oxygen.
To commence the debate for the benefit of fluid therapy and exclusion of negatively associated correlations, Sarid and Deacon 2005 conducted a detailed, highly referenced critical review on fluid therapy in critically injured patients. He stated that venous access and fluid therapy should be considered to be an essential element of pre-hospital advanced life support fluid therapy in the critically injured patient. initiation of fluid therapy should be based on a clinical assessment, most importantly the presence or otherwise of a radial pulse with adequate systolic blood pressure. Soride and Deacon 2005 also summarized that the goal of pre-hospital fluid therapy is to avoid hypovolemic cardiac arrest during transport, but at the same time not to delay transport time or increase systolic blood pressure. Expansion on these variables will be expressed later. Firstly, though, a retrospective article by Hampton et al. And further supported by Revel, Porter, and Grievous 2002 found that when controlling covariates such as age, gender, and mechanism of injury, results demonstrated a statistically significant relationship between pre-hospital IV fluids and decreased in-hospital mortality. This can be expressed with a 0.85 hazard ratio, 95% confidence interval, and a 0.03 p-value. Total volume also had no influence on the statistical significance, which is an important note since over-resuscitation with large volumes have shown to have detrimental effect on the patient. Further information by Soride and Deacon outlined the clinical concerns surrounding IV fluid therapy, in particular high-volume therapy. Coagulation from reduced concentration of hemocrit, clotting, and clotting factors is one such concern as have been presented in uncontrolled hemorrhage. Since isotonic fluids have greater volume effects on patients with shock compared to patients with no signs of shock, this creates the driving force for successful fluid resuscitation and patient survival. Expanding on this topic in a recent systematic review of controlled animal studies within Soride and Deacon's review, reflected data from an additional study which concluded that moderate volumes of fluid improve survival in all models, but that excessive amounts were sometimes detrimental. Finally, an animal study found that the systolic blood pressure threshold for provoking new bleeding was approximately 90 mils of mercury, independent of time from start of bleeding. This information reinforces the need for accurate and effective treatment protocols performed by competent, trained personnel who are aware of the dangers of blood pressure and its influence on coagulopathy and patient survival. Fluid therapy will remain an effective treatment for hypovolemic shock, providing patient treatment protocols are thoroughly understood and problem-solved effectively. Further to this, Soride and Deacon conveyed risk factors associated with high excessive systolic blood pressure in patients presenting with shock. The scope of research broadened with some focus on additional clinical procedures. One treatment has been the use of hypertension, or clinically named hypertensive resuscitation, whereby the absence of fluid therapy to induce a hypertensive state would improve patient outcome and lower further hemorrhage. However, this treatment protocol contradicts some important physiological requirements of blood pressure and organ perfusion. For example, patients with severe traumatic brain injury with a Glasgow Coma scale of under 9. These patients deserve special treatment, and as the injured brain does not tolerate even short periods of hypertension or hypoperfusion. Several studies have found a significant association between pre-hospital hypotension and worse outcome in severe traumatic brain injury. Studies have also linked pre-hospital advanced life support therapy to improve outcomes in the trauma subpopulation, and is finally further supported with more articles by Soride and Deacon, which presented data from a randomized study of 110 hypotensive patients with suspected continuing hemorrhage to a target systolic pressure of over 100 or over 70, but found no improvements in survival with the hypertensive subgroup. Overall, it is vital that fluid therapy is continued in the treatment of hypovolemic cardiac shock to ensure organ perfusion and cellular preservation. However, systolic blood pressure is a driving variable that significantly influences patient survival and one that requires close maintenance in order to ensure greater likelihood for improved patient outcome.
Another example, as mentioned earlier by Janella, is septic shock. It has been seen that early goal-directed therapy of hemodynamic resuscitation and fluid resuscitation has seen a decrease in mortality and morbidity as opposed to patients who didn't receive early goal-directed therapy. These results can be seen in not only one research, but several, including the papers of Rivers et al. 2011, Anane et al. 2005, Nguyen et al. 2006, and Hollenberg et al. 2014 MFU. Some numbers from the studies illustrate this point on the board now. Fluid therapy helps, described by Nguyen et al. 2006, by restoring systemic oxygen delivery through manipulation of the preload, or the volume, afterload, or the blood pressure, in contractility, or the stroke volume, to preserve effective tissue perfusion while avoiding excessive increases in myocardial oxygen consumption caused by tachycardia. Furthermore, most journal articles agree with this notion rather than opposing it, with the closest article I can find to go against this idea was written by one person, Renovell 2010, who talked more about volume and different types of fluids rather than the direct negative effects of fluid resuscitation in severe sepsis or septic shock cases as we would be seeing as paramedics.
Complications are apparent in all forms of treatment, yet likewise with IV fluid therapy in pre-hospital settings, correct education and training minimize detrimental occurrences so not to overcome treatment benefits. Malamed 2009 presents risks of invasive cannulation and fluid administration. Infection, catheter shear, infiltration, hematoma formation, and air embolisms are such complications associated with poor practical skills, yet such occurrences are uncommon due to employment processes. Within the QAS, a degree-level qualification is required, followed by rigorous training in a graduate program, and finally a supervised period prior to full qualifications. Major treatment controversies follow uncontrolled hemorrhages and patient transport delays, which have produced countless studies. Likewise, with the vast majority of publishments, Elder and Deacon's 2005 study, covering both of these major controversies, deemed results inconclusive due to varying patients and distances to hospital. Contradicting delayed IV access, Revel et al. 2002 proposes successful placement of an intravenous line more difficult due to compensatory mechanisms causing peripheral vasoconstriction through shock progression. As crystalloids cause increased water content, Casey's 2014 fluid therapy article states that excessive administration can cause harmful effects such as edema. Specifically, respiratory and head trauma cases contraindicate the use of fluid therapy, as edema in these regions can cause mortality. A 2015 study conducted by Garatz et al. Concluded that excessive IV fluid administration of greater than 1 litre increased patient likelihood of receiving blood transfusions in the hospital's EDs. Without completely contradicting the detrimental findings of these studies, protocols and rules have been set in motion within emergency organisations such as the QAS 2015. Critically burnt patients, for example, have contraindications published by said pre-hospital emergency establishment, including patients with significant facial, neck or upper chest burns with high potential for airway or ventilation compromise. Precautionary use is also presented for the use of fluids in cases involving heart failure, renal failure, and uncontrolled hemorrhaging. Furthermore, it would be impractical to discontinue fluid therapy, as many pre-existing factors increase hypervolemic rate, according to Thoms et al. 2007. Kidney diseases causing increased urination, diuretic drug use, and vomiting and diarrhea infections predispose faster onset of hypervolemia as body fluids have formally declined. This is identified by clinical manifestations of shock, plus evidence of dehydration such as dry tongue, reduced skin turgor, and excessive thirst, presented in Curtis and Ramsden's 2011 Emergency and Trauma Care. Fluid therapy may not necessarily affect fatality rates in these circumstances, however patient discomfort and the potential for tissue impairment will increase.
In conclusion, we believe that venous access and fluid therapy should be considered essential elements of pre-hospital advanced life support in critically aged patients. Initiation of fluid therapy should be based on a clinical assessment to determine if there is a need of fluids or not, to help maintain the airway, breathing, and circulation so that hypovolemic cardiac arrest is to be avoided during transport, and also to maintain cerebral perfusion to reduce secondary brain injury. Also deciding if fluid therapy is needed, or if so, that transporting patient won't be delayed. Remember giving fluids to a theoretical level so that there won't be any adverse effect. And remember, keep calm and start fluids.
Created using Powtoon.